It's 12:16. Should we go ahead and get rolling? Looks like we're settling out. All right, we shall get rolling. Thanks everybody for joining. Sorry, I think I missed the last call, if I remember correctly. So nice to see everybody back. Just feel like it's been forever. It's only been a couple months. So the big topic that folks have been asking questions about or most interested in is about monkeypox. And so we've actually invited Dr. Mendoza and Dr. Tassini to come and talk about that because they are the experts and we'll have more information. I think briefly I can say from a COVID incidence, I think we're at about an 8.6% rolling incidence, up a little bit from 5.5%. Although if you look at the trend line, it looks to be plateauing a bit. Monkeypox, I believe, and you guys can correct me, I think we've had 106 cases in New York State, roughly 12 in Western New York. I think it was 6 in Monroe County. 85% plus have been in folks identifying as gay, lesbian, or bisexual, and predominantly in like the 20, 30-year-old age group, if I remember correctly. So, I know the big question or concern, especially with the recent announcement in Illinois that there was a daycare worker that had potentially exposed multiple children, was the risk of exposure. It looked like, from that reading that to date, those kids have tested negative, but that most of the pediatric exposures to date have been from living with close family members who are positive rather than exposure in the outside world kind of thing. But so I think knowing that those are immunosuppressed and children seem to be the most adversely affected with monkeypox, although it still seems that the incidence is very low. Nevertheless, as we started talking about approval of vaccines, which Bob Adams is going to talk about, and incidence and testing in our area, we figured it'd be great to have the experts. So I'm actually going to shut up and hand it over. Maybe we'll start with Mike and Brenda, and then Bob can talk about the vaccine component of it that just got approved.
Sure. Thanks for having me back. It's always nice to come back when there's another global pandemic. It's hard to make a conclusion when the N is 7 here in Monroe County. We have 7 cases confirmed here in Monroe County. All of them are men. All of them are men who've had high risk sexual behavior with other men. I'll tell you, the CDC and WHO and others have been reluctant to call this a sexually transmitted disease, but it is transmitting like a sexually transmitted disease right now. Which isn't to say that it's only going to be that way, but that's the kind of behavior that is leading to transmission. There is household contact. So what we're saying is that it's sort of vigorous skin-to-skin contact. So the kind that you might have between a mother and a parent and a child, what have you, or in a close household, perhaps something like a Hep B would be a household contact, or herpes simplex, for example. But I'll tell you, I don't think that this is something that's going to be generally transmitting in the public. There is still a lot of reluctance, among other health agencies to take out the stuff about it being possible to transmit on doorknobs and elevator buttons and the like, and I'll let Brenda chime in as well. But that is, while possible, very, very unlikely. I think that would be highly, highly unlikely. And I say all that to say, we're getting a lot of calls in the health department, literally all around the clock, from clinicians who are worried about monkeypox. And this is just not generally community transmission at this point. I want to encourage all of my colleagues out there not to forget about poison ivy and syphilis and all the other things that cause rashes in people, because that is far more prevalent than monkeypox is right now. So like I said, this is currently, at least in Monroe County, and what we're seeing at least across the state, is that, what we're calling vigorous skin-to-skin contact. So, shaking hands generally is not vigorous skin-to-skin contact. So you want to provide that education to your patients, some reassurance, and heighten your awareness for other things that cause rashes, because most things that cause rashes these days are not going to be monkeypox for now. If you're going to test, and I guess I would say push back when you have a patient who just went hiking and rolled around in a field of plants that had 3 leaves really push back on ordering a monkeypox test in that case. But if you're going to order a monkeypox test, I want to say everybody who has a test pending should be told to isolate until the result comes back. 3 of the cases that we had identified were in people who were not told to isolate, and they had high risk sexual behavior, and none of these were ordered within an AHP practice. So as other clinicians. But if you're going to order a test, please tell them to isolate until basically proceed as though they might have monkeypox and act accordingly, because we do want to contain the transmission as best we can. So they should isolate at home until further notice. We don't need to hear about every test that you order. We don't want to hear about every test that you order unless you have a high index of suspicion for a monkeypox case that has an epidemiological link that we would want to investigate from a contact tracing standpoint. So the classic story that has been present in almost all of the cases so far is that a gentleman has gone to a camp, I think they call them camps, where the sole purpose is to meet up with other people and have sex. So if you get that story, please call us, because we're going to want to do some contact tracing. The direct phone number to the back office, the EPI line, many of you have it, is 753-5164. Please don't share that with patients. That's really the number to get back to my team, 753-5164. And so please let us know if you think that you have a high risk situation, a high risk patient, but don't let us, we don't need to know about every test that goes out. The U of R is doing testing in the U of R labs. We don't need to have any role in any of that. The only time we would need to have a role in getting a test is if you plan to send them to Wadsworth. And in general, there's really no need to send to Wadsworth unless you have a patient who is uninsured or has a high deductible or something. We would process that specimen through Wadsworth, and then we could forego all of the usual payment stuff. But the vast majority of tests that are being done, certainly within HP, can be done at the U of R lab without our involvement. So just let us know if you are worried from an epidemiological standpoint. In terms of the vaccine, I guess we'll get into that later on, but you may have heard yesterday that a new plan for providing the vaccine intradermally in 1/5 the quantity of the previous dose has been approved by the FDA. We got word from the state health department yesterday evening that they're not yet going to approve that for use in New York State. We're going to learn more tomorrow, apparently, on a call. But for now, that's not going to be the approach in New York State until further notice. But I do think there's a lot of debate about whether the intradermal is the right way to go. There's some good science, well, one paper, but it was a well-done paper that says that intradermal can be useful in this case. The challenge, of course, with intradermal is that it's not easy. Vast majority of nurses would need some practice doing intradermal because it's not typically used for vaccines. So more to come on vaccines, I think, in a little bit, but I'll pause there, hand it over to Brenda if you want to keep me honest.
Yeah, I would really just echo everything you said. I have a few slides, mainly like to get some resources up there if folks want to see that. Now comes the trick of screen sharing, which for some reason is more difficult on my laptop here, my MacBook. So I think we've got this. And looks like it's working.
Looks good, thanks.
All right, woohoo. So yeah, this is again publicly available information. As Chad already went through, kind of where we're looking at the state, and I just wanted to kind of focus, like, everyone take a breath. It really, New York is the U.S. epicenter. It really is New York City and Metro New York City. But we do have some cases here in the Western Central New York region. And this was a good paper published in July, I believe, that kind of looked at globally to understand, again, where we've had a few cases here, but to kind of see what the features are and demographics were mentioned, that really it's that like, yeah, that vigorous close contact, that really, prolonged or, very direct close contact is how it's spread. In that classically we think of monkeypox as having a prodrome of this febrile illness and then the rash. And what we're seeing now is that the rash lesions, mucosal lesions, may be really at the start, and that the prodrome may actually be kind of concomitant symptoms, but they do proceed. And that again, as was mentioned, this is traveling with other STIs, and it it's kind of the way to get that close, vigorous contact is through sexual or other very intimate contact. And I think this was kind of some of the best stuff out of the paper, was to get an idea. The other feature of this is that the lesions, partly because of their locations, may not seem like when you look at monkeypox in a textbook or you think of what a smallpox lesion would look like. But again, certainly for now and in our region, the epidemiologic risk factors should really be there. As Dr. Mendoza was saying, that's the cases we're seeing are really, spread out of these social overlap of social sexual network. And that's how it's spreading, by needing that kind of prolonged close contact. But you can see it can be more ulcerative than we think of that kind of pustular umbilicated lesion. And that mucosal lesions and the presenting symptom of pharyngitis or proctitis can really be what patients are presenting with. So again, is this poison ivy or is it monkeypox? It's poison ivy. Is this pharyngeal gonorrhea or monkeypox? That's more of your diagnostic dilemma there, I think, with the right epidemiologic risk factors. And then for testing, again, UR Medicine Labs does have the test up and running. So it's an orderable test now. And it's vigorous swabbing of, if a patient has two distinct lesions, only need one swab per lesion. This evolution of the specifics of testing have changed. So it would basically be like 2 orders, send 2 separate things, and just really get into that lesion. They'll say to unroof it. Some of these lesions don't have a roof. So just be practical, really get in at those lesions. And there are other options, but again, capacity, certainly our lab capacity is limited. This isn't just like let's throw it on this machine. It's a completely manual test. So again, don't overwhelm the system with this. This patient's just really worried, but has 0 chances as monkeypox. Don't send it just to be complete. And for treatment, again, some options here, stressing that hospitalization is very rarely indicated. In New York City, it's been certainly less than 10% of cases. And the reasons for hospitalization are often pain control with that proctitis and pharyngitis. And for the pharyngitis, also inability to take PO. So it's really for the supportive care. And secondary bacterial infections are something to consider. And antiviral treatment, should you have a patient who tests positive, things to consider that would be if they're at high risk for severe disease. And the one kind of unique aspect of this than other things that you think make everyone at high risk for severe infectious disease would be patients with skin conditions like severe eczema, other exfoliative skin conditions. And that can overlap again with the pediatric population. That certainly, less than 8 years old, and certainly couple that with, a kid with eczema, that's going to be a very high risk kid. And sometimes just based on the nature of the lesions in the genital area, on mucosa, those would also be reasons to treat to limit the severity of the disease. And tecovirimat, or TPOXX, is really the main treatment being used. And this can be obtained through the CDC. They've streamlined things, so it's not as much paperwork, and it doesn't have to be done like in real time. So that's an option for all providers to contact CDC, work through that. They have great resources on their website. We are also in the process of getting our own IND for this through our ID division. And so through the Access Center, how you would normally contact to get, you know, like a curbside kind of support for things, we have several of my colleagues will be listed on this IND to be able to do a telemedicine visit and prescribe Tegoprubart if it's indicated. So this is in the works. It's sitting with our IRB right now, but that'll be a great resource for the region. And for infection prevention, always the hat I wear. Again, to stress healthcare transmission, extremely, extremely, extremely rare. You know, when I looked at this a little while ago, worldwide, there have been one report in this whole global outbreak, and it was someone touching lesion without gloves on, which I think most of us don't touch rashes, certainly wet rashes without gloves on. So really, that's the big message. I know the last thing we all want to think about is another pandemic coming through our offices and hospitals. But really, this is not the same. And so I put this here, it's the same PPE as COVID, but it's not the same risk. It really isn't. The contact precautions is really the key here. Wear gloves for a rash, keep rashes covered. If you really think someone has it, it's the full, the same full PPE that you would use for COVID. Private room, but no special air handling needed. And again, it's direct ungloved contact with lesions is what's gonna put something in a very high risk situation. Because again, you have to have that really, you know, vigorous direct contact, and that post-exposure prophylaxis through vaccination would likely be offered in those truly high risk scenarios. And so here are some resources. Again, CDC has a gazillion web pages about this. New York State also has general information and to kind of keep aware, and they do great webinars. And you can access those at any time, download a PDF of the slides. Locally, we have through our CEI, which is a state-run initiative with UR faculty organizing it. They've done a webinar with Jason Zucker, who's at Columbia. So he's kind of been like the monkeypox guru there in the epicenter. So he gets some great real world experience. Right now, I was going to have one of them on here, but they're giving an echo, an SEI echo on this topic. Again, that would be available on the CEI website. My colleague, Paul Greenman, did a Connections with Evan Dawson show. I'm sure there were others on there as well. Something to listen to in the car. So lots of stuff out there. And again, also as you know, as ID, we're always available. If there's a question you want to talk through, don't hesitate. And that was what? All right, and we're back. So whirlwind.
Terrific. Bob, I don't know. Did you have anything you wanted to add?
I don't know as much that I could really add, you know, after that great information presented by Dr. Mendoza and Dr. Tassini. I think we'll all wait to see what New York State does with reduced dosing and intradermal. I think that's kind of the next question.
Mm-hmm.
I set you up, Bob. I'm sorry. I like let Elvis and Jerry Lee Lewis go on stage. I'm like, hey, do you want to come out and play an instrument now? This week? Sorry about that. So I think so that's huge. I mean, I think it kind of supports everything that we've kind of been saying to folks as they've called, that it does seem to be fairly low risk in the immediate area, very high risk amongst certain populations, but fortunately does not seem to have the widespread transmission, certainly nowhere near COVID, or certainly not catching up to the press interest at this moment, at least where we're at locally. But of course, as we've seen before, that could change. And so I, in particular, on the back of being the guy that said, oh, we really haven't seen much COVID here in March of 2020. I didn't want to be the guy to be like, oh, monkeypox isn't a big thing. And then all of a sudden, everybody on the screen has pustules on their face. And so I just figured it'd be better to have somebody who knows a lot more about it. So thanks, you guys. While we have you guys here, you know, as far as other things that I wanted to bring up, the other questions have been, a few people have reached out asking about we're getting into that fall season where there has been a lot of discussion about the potential for a bivalent vaccine, specifically including maybe kind of boosting against the BA.5 strain. And should we be advising people to wait at this point to get that next booster dose? The experts are here. Most of what I've read so far seems to say get boosted soon. That the bivalent may or may not necessarily be the secret bullet, and for all intents and purposes may have missed the wave of BA.5 when and if it comes out. And so, in fact, the other day, I can't remember the exact numbers, but it was basically if you're under 60, do not have major health problems, respiratory in particular, and have been vaccinated and boosted, the likelihood that you're going to have a significant manifestation of a repeat exposure or primary exposure to COVID is extremely low at this point. So the booster is the secret, not necessarily a particular booster. So does that jive with the experts' impression of the world?
Right. So obviously at this point, we would recommend everybody get their booster. The big question is, sort of a logistic one. Will getting your booster now change your eligibility for if and when a bivalent vaccine becomes available? So that's sort of theorizing at best. I don't think that's likely. I think, it's unlikely that somebody who got their booster today is going to be ineligible for whatever bivalent comes along. And obviously being no harm to getting the booster for any other reason, I say just go get it. Yeah. Is it going to be that beneficial? Honestly, don't know, because the boosters were against the initial strains, which have largely gone away. And we know that BA.5, the subvariant BA.5 has been able to evade both natural disease-acquired immunity as well as vaccine-induced immunity. So I think that's the big question. I would still say to everybody, get your booster as soon as you can. And then when the bivalent comes out, if it comes out, then you can get that then as well. People should know that Novavax is available. The Novavax is indicated for people who did not get their Pfizer, Moderna, or J&J initial series. It's a protein it's a different mechanism. It's a mechanism that's much more conventional. It's what we use in a lot of the other vaccines. So for those people who were holding out on the mRNA vaccines because they wanted something, quote, more whatever, scientific, conventional, whatever, the Novavax is available. I don't honestly think that's going to be a lot of people, but it is out there. Yeah, I don't know, Brenda, Bob, you want to add anything?
Yeah, I would say the same thing. If you're truly due for a booster, get your booster. Yeah. The whole goal is preventing severe disease, and it will accomplish that by and large. And I've heard that the bivalent with the BA.5, we're thinking like October at the earliest. So don't sit around waiting for it. Just get it. It's here. COVID is here. BA.5 is here. These vaccines are here. do what you can to protect yourself.
We've largely seen the worst of BA.5 in this community already. I mean, we saw an early peak of BA.5, and now we're in the low transmission zone, while a lot of the country is still medium or high. So, for better or worse, we got BA.5 sooner, which I think puts us in a better position as we head into school and colleges and so forth reopening. So I think we're in a good place in this community. But I'd still encourage the boosters and the bivalent when they come out.
There are some questions in the chat. Dr. Mendoza and Tassini, I believe. One is, do you have any concerns about polio?
Oh, man. Yeah, I have concerns about polio.
Get vaccinated.
So there was a case of polio isolated in Rockland County in a person who was exposed to somebody who'd gotten the oral polio abroad. So not the wild type polio, thankfully. You may have seen reports that polio has been isolated in the wastewater in Rockland and Orange counties, I want to say. Many people are asking if we're doing wastewater testing here. We are. To use a medical analogy, it is not yet known whether seeing polio in the wastewater is clinically significant. It's barely statistically significant. So, if and when we see polio in the water here, it doesn't necessarily mean anything about actual polio in the community. you can get the polio in the wastewater from somebody who got OPV abroad and is totally asymptomatic here. But yes, we are concerned. We have been told, and we are vaccinating adult vaccines for polio for anybody who is unsure if they've been vaccinated for polio, who has epidemiological links to Rockland, Orange County. So that is coming. But as to whether this becomes more widespread, obviously we're just sort of following very closely at this point.
I think our overall high vaccination rates in our community is very protected.
Yes. Yeah, Rockland County has they have a lower vaccine rate for a number of reasons for polio.
Then just kind of working down the list of the chat, do you know if there's any combined flu, COVID vaccines being tested?
I don't believe so. I just saw the
Yeah, I don't know about in the same. Yeah, I think they
just
both
saw
have
the
to change so
announcement
much.
The announcement went out today for VFC and VFA for the flu vaccine for the season already. So I'm guessing it's not going to come this year.
Gotcha. And does the advice for booster still hold for the second booster dose? Yes.
Yeah,
Yes.
if you're eligible and due for it, yeah.
And then any leads where someone can get the Novavax, has it been distributed yet or available?
I don't know.
Do you know? I don't know who may be stocking it, actually.
I'll get back to you, Chen.
I see that it was available, but Mike would probably know better than anybody.
I'll get back to you, Chen.
Okay. The only other thing that had come up was questions about rebound from Paxlovid, and should we be taking a more conservative use of Paxlovid versus just anybody who wants Paxlovid gets it, which was seemingly the case. Again, I'll defer to the experts. Everything I've read seems to be in kind of the high risk group. They should be getting Paxlovid. Lower risk groups, asymptomatic, probably not worth running the risk of developing resistance to the drug, and that the concern now as far as rebound, some of it may be, thinning, for lack of a better word, viral particles during the course of Paxlovid, that then afterwards, viral particles are being shed, but maybe not be actively transmitted. Certainly there are some rebound cases where they're actively symptomatic, but it doesn't seem that it's like a widespread thing necessarily that should dissuade people from using it in high-risk populations. But does that jive with what your guys are saying?
Yep.
Yep.
And one person had reached out to say that they had some difficulty finding Paxlovid. I had not heard that. I had not heard there was any shortage, so maybe it was just one particular pharmacy, but to my knowledge, I've not heard anybody else say that when they wanted to prescribe it, they could not get it for a patient fairly easily. So that's all I have on that. Those are really the only topics that have come up. Like Mike said, I think largely in the area, we're seeing a relatively low level of COVID. Certainly hospitalizations are, would persist, with some, but it's comparatively when we were in the Delta surge, we're nowhere near the hospitalizations and ICU rate. And oftentimes we're still people getting hospitalized and found to have COVID more so than hospitalized with COVID. So it still remains kind of a low level thing in the hospital setting. And, we have reasons that patients or that hospitals are overrun because of nursing home transfers and that kind of thing, but it's not because we're high census of COVID that's cluttering the halls or anything like that. So largely we're seeing some delayed care that's having effect and delays in discharges because of nursing homes and staffing issues and not having full open bed contingents. But it's not because of COVID problems. So all the emails that you may get from Mike Apostolakis saying that we're in high census states and the ED is busy and try to keep people out as much as possible. It's not a COVID issue as much as it is just a discharge and placement issue as much as anything right now. So I think those are the big issues I had. Bob, was there anything else that you wanted to cover today from a pharmacy standpoint?
No, I think we covered it all today. Talk about monkeypox and everything.
Perfect. I don't know, Brenda or Mike, are there like third and fourth global pandemics that we should be thinking about or kind of keeping an eye on now? It's like the thing.
Yeah, I don't know. Yeah, when I heard about the polio case, I think it was on like a state webinar about monkeypox. It was like, seriously, like, can we, like, how much can we like dovetail on here?
Yeah, yeah, we're already done laughing in the health department. It's
Yeah.
just
I was like, we need like just an Ebola outbreak or something just to round up.
don't even go there.
Yeah, you don't want to like
Let's
summon
say finish
anything
the summer
up.
strong. Any other, Renee, anything else that you had? No, okay. Any other questions that folks have? They want to drop them in the chat. They want to come off mute and bring up. I don't have any other topics for myself. All right, I'm not seeing any popping microphones. Okay. So thanks to Dr. Mendoza and Dr. Cassini for coming. I appreciate you guys educating everybody as always and coming on relatively short notice in the last several days. So appreciate it. Appreciate you being here. We will reconvene in a month for the AHP group. I just want to give out the shout out because we're going to be running up against it by the next time we meet. October 19th is the AHP clinical grand round. So if you haven't kind of blocked that off on your schedule, do so. That's going to be kind of the multiple small feedings of the mind kind of format that we've got planned. So it'll be over Zoom. We'll have breakout rooms to triage folks appropriately for pediatric versus adult topics. And then obviously we'll record it so that if you are torn between which ones you want to go to, you can catch the other side on replay. So there'll be something for everybody at this point. So we will see you again in a few weeks and then obviously see you again on October 19th. Thanks, everyone. Have a wonderful rest of the summer.
Thanks all. Have a good day.
Yeah.